Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh and good day. Thank you for the invitation. In these challenging times, we receive all sorts of information that come from everywhere. Maybe something we stumble upon by accident, or perhaps something specifically related to you by the person sitting next to you. How can we determine if it is true or is it a fake? It's always sensible to be careful. It shouldn't just be applied in our social lives, it should be involved in every aspect of our activities. If you happen to receive a printout like this, 15, huh? We should always ask ourselves if this is believable. Look at the context. Isn't that something we always do? Do they make sense or do they not? In this example, 15 appears reasonable, provided we can explain why is there a reversal in trend from the last 2 days. You have heard of Deep Blue defeating Grandmaster of Chess Garry Kasparov in 1997, or AI defeating human ace in F-16 dogfight last year. But this fellow here, the Hematolizer XN1000, is no Deep Blue. It has limitations as alluded by the previous speaker. If it says thrombocytopenia and this came out from the blue, then we need this piece of natural equipment to pierce through the eyepiece, see how many playlists is observable in a high field to do a verification. Of course, there are other things to look out for as well. Now that we have determined that it is true thrombocytopenia, it is then time to identify the cause. Majority of thrombocytopenia presenting in adulthood are acquired. Nevertheless, there are rare instances of congenital thrombocytopenia that is discovered only during adulthood. Hence, if you are seeing someone for the first time, it will be worthwhile to explore in detail two aspects. First, the family history, and secondly, the bleeding assessment tools. What to look for in the family history? Ask if there has been anyone with thrombocytopenia among the parents, siblings, as well as uncles and nephews, including diagnosis of ITP, which is often the case. I even go further by asking about dengue. Presence of two individuals besides the index patient increases likelihood of congenital thrombocytopenia. Direct visualizations of the platelets is the initial triage. Either large or small platelets are present. Presence or absence of a couple of related clinical signs will help, provided we know what to look for, such as absent radii, hearing loss, early onset cataract, etc. We will also start thinking of congenital when they are resistant to treatment, that the platelet count refuses to nudge. Diagnosis like amegakaryocytic thrombocytopenia comes into mind. Bleeding assessment tools was developed by the International Society of Thrombosis and Hemostasis ISTH, whereby 14 categories of symptoms are evaluated and scored. A total score of more than 4 in males or more than 6 in females should be considered significant and require further investigations to explore defects in the hemostatic system. A brief recall on the life cycle of thrombocytes helps in the visualization of the acquired causes of thrombocytopenia. Thrombopoietin, a hormone produced by the liver, induces the proliferation and maturation of megakaryocytes from pluripotent stem cells in the bone marrow. A single mature megakaryocyte at around 100 micron in size is able to produce 2,000 to 4,000 platelets as it flakes her cytoplasms away into 2 to 3 micron discoid platelets that will eventually change shape upon activation. Platelet survives in the peripheral blood for approximately 7 to 10 days. One-third of peripheral platelets are sequestered as a platelet pool in a normal-sized spleen. Any factors that reduces its production in the bone marrow, as shown in this yellow box, or increases her removal in the red box, will lead to thrombocytopenia. Obviously, any growth and developmental process in the human body rely on the supply of nutrients like B12 and folate. Any insult to the marrow microenvironment, like exposure to chemotherapy or toxins, infiltration by cellular as well as acellular elements, will impair megakaryocyte activities. Intrinsically impaired megakaryocyte production and development, as in aplastic anemia or myelodysplasia, is another reason to be considered. Similarly, increased consumption of platelets in addressing vascular endothelial injury from whatever causes, most commonly sepsis, or sequestration of platelets in an enlarged spleen, or by antibody-mediated platelet destruction, either directly via ADCC or indirectly via Fc gamma receptor capture in the spleen, as in ITP, or in the imbalance between pro-survival BCL-XL and pro-apoptotic signal BAC are the other contributors of thrombocytopenia. Acquired causes of thrombocytopenia are numerous. How we respond to each of the situation is delineated by its underlying mechanism. My colleague has elegantly described each of the cases. I shall not repeat what she had touched on. Suffice to highlight a couple of take-home messages. Firstly, verify accordingly. Look at context. Secondly, don't ignore congenital issues just because you are in adult medicine. And finally, understanding the biogenesis of platelet is the key to your understanding of thrombocytopenia and how to address it. Thank you.